Hello, I'm Deborah Chieli, a nationally board certified nurse practitioner with specialty certification in lifestyle medicine.
And I'm Susie Spell, a nationally board certified nurse practitioner, also certified in lifestyle medicine.
The following interview was part of a series that informed our presentation at the 2023 Annual Conference of the American College of Lifestyle Medicine, ACLM, titled Nurses in Action, How Nurses Operationalize Lifestyle Medicine in Modern Settings, and You Can Too.
In this series, nurses from diverse backgrounds and practice settings and their champions tell their personal and professional stories about discovering lifestyle medicine and how they're implementing it across a wide range of settings.
Nurses are the largest health profession in the United States and globally and have been voted the most trusted profession here in the U.S. for over 20 years. Learning about and incorporating the pillars of lifestyle medicine fosters full scope of practice and the ability to answer the call to lead by the National Academy of Medicine with their report, Future of Nursing 2020 to 2030, Charting a Path to Achieve Health Equity.
We hope these stories of success will inspire conversation and drive creative solutions to better address inequities in healthcare. Continued growth of nursing expertise in lifestyle medicine will expedite our nation's ability to address the public health emergency of chronic lifestyle diseases we currently face.
The power of nurses to create innovative solutions when combined with the practice of lifestyle medicine allows nurses to express their full potential while simultaneously addressing the salient issues of health equity, the epidemic of chronic disease, and the provision of truly patient-centered whole person care.
When nurses are empowered to lead with an interdisciplinary and multi-sector practice, they answer the call of the National Academy of Medicine to dissolve barriers to care and improve health for themselves, the nation, and every global citizen. Enjoy the interview. Today's guest is Loureen Downs, a doctorally prepared family nurse practitioner in Southern Florida. And Dr. Downs is really special. I can't wait to talk to her. She's a leader in education at Florida Gulf Coast University, where she is professor and the founding director of the Doctor of Nursing Practice, or DNP program. She has decades of experience in nursing, and over 20 of those have been spent in nursing education. And like Deborah and I, she's passionate about lifestyle behaviors and chronic disease prevention. Her clinical, scholarly, and research interests are primary prevention and managing chronic diseases through healthy lifestyle behaviors. Dr. Downs continues to contribute to the field of nursing as well as lifestyle medicine in many ways. She has been the author of several peer-reviewed journal articles. And in addition to those publications, she's a sought-after national and international speaker at professional conferences. And if all that wasn't enough, she's also developed an instrument called Motivators and Barriers of Healthy Lifestyle Behaviors Scale that has been used internationally. And she's also co-edited a new textbook, Advanced Health Promotion and Disease Prevention for Advanced Practice, Integrating Evidence-Based Lifestyle Concepts. So I know Deborah and I are both very excited to talk to you, to hear what you have to say about nursing education and moving the needle forward when it comes to health promotion and lifestyle behavior. So welcome. Thank you, Dr. Downs, for joining us.
Thank you for the warm welcome. Appreciate it. I'm delighted to be here and I look forward to our conversation.
Yes. So, what I'd like to start with, I always ask people about their origin story. Maybe you could tell us about your current role and how it may or may not look like everyone else's role in nursing, and how you got to that place, like how you really got interested in lifestyle and how you ended up there.
My start for lifestyle really began some year, almost 26 or 27 years ago, when my son was about 4 years old. He started developing asthma, and we could identify the triggers very readily. He would go into preschool, and they may have a day where there was a fun day where there might be ice cream or something like that. And then he would be triggered to have an asthma attack. And I was fortunate enough to be involved in a faith-based organization that really promoted a lot of healthy living. And from that was able to put the connection with the diet, with ice cream, the dairy products, sugar, and the asthma triggers. And so we started going pretty much vegan soon after that, where we had a presentation at our church by a renowned public health person who knew a lot about healthy living and did some cooking classes, taught us how to make food without using cheese and things like that. And so that sort of was my start. I was a nurse at the time. I'd worked in cardiac rehab. I had seen a lot of health conditions as a result of lifestyle behavior. Not sure I really always put the two together at that time because I was a young nurse. But as time went on, I definitely could see the connection. And then Dean Ornish's work was also beginning to be published during that time as a young nurse. And so I was also beginning to read that literature. And I just started falling in love with why would someone want to go through a heart attack and bypass surgery instead of doing diet and preventing it using some of Dean Ornish's work and Dr. Pritikin.
I love that story. Not that I love it for your son, but you had a personal journey.
And I'll add that because we were able to identify the trigger so early, he's now 31 years old and he's never had an emergency room visit as a result of his asthma. It also helped having a mom who knew what to do probably many of those times and got him into intervention early. But yeah.
Yes, that's amazing. So one question I did want to ask you is that you said initially maybe you didn't put the pieces together as a young nurse, but then it became more apparent. And you found the work of Dr. Dean Ornish. So I'm just curious, in that arena, in cardiac care at that time, was Dean Ornish's work really prominent, or did you seek it out somehow? How did that happen?
It was beginning to come to the surface as part of my role in cardiac rehab. So, in educating patients, they didn't use it in terms of reversing, but definitely part of the education for patients, helping them to understand that there was some connection with diet and physical activity and cardiac disease. And that's part of the role of cardiac rehab.
Another question I had was, would you be able to touch more just for a second on the lifestyle program that came in your church? What was that?
Gwen Foster, she was the health czar in Philadelphia so many years ago. And so she promoted for the city of Philadelphia healthy living and worked with their mayor at the time to get the city on a health program. And it's been so many years now, maybe 25 or so years ago. I don't know if you're familiar with her. She did public health at Loma Linda University. And so she was part of my faith-based organization, the global organization, and would travel around doing these health talks and cooking classes. And I got exposed to that. And with my work as a nurse in cardiac rehab, it was really I just fell in love with all of it.
That's amazing. And then if we fast forward a little bit to your current role, how long have you been at Florida Gulf Coast? How has your career there evolved?
So I've been here about 18 years, starting about my 18th year now since 2006, 17 plus, and came here as an assistant professor soon after graduating with my PhD degree from the University of Connecticut. But while I was doing my PhD, I was also interested in lifestyle and promoting health. As part of my dissertation, I did the instrument to develop motivators and barriers of healthy behaviors because as a nurse, I would see patients being informed that you need to change your diet or you need to eat better or exercise or do these things, but we didn't really address why they could not. And also the flip side is how could we motivate them if we could understand their facilitators of lifestyle behaviors. And so I got into the literature to identify what did the literature say about these motivators and barriers. And so that's how that instrument came about. But I was also particularly interested in so fast forward to your question. I've been here 17 plus years and I came with that lifestyle background as part of my dissertation and work and my doctoral work. And we had a master's program in the family nurse practitioner track, and that evolved over several years to a doctoral degree in 2016. As the founding director of the DNP program and an interest in lifestyle behaviors, I thought, what a great opportunity to start to integrate nutrition into the curriculum. As part of that, I started doing nutrition as medicine And I partnered with our nutritionist or certified registered dietitian faculty. We only have one here in our College of Health. And she we had an interest also in healthy eating as her role, of course, right? So we invited her into several of our primary care courses to talk about the relationship between nutrition and older adults, nutrition in women, nutrition and pediatrics. I was able to get that integrated into the curriculum. Sometimes it's when I'm teaching, it's probably a little bit more intense, and other people are teaching, it's probably not as intense.
So there's one example of the way that you collaborate or have collaborated. And what do you think have been the essential elements for you to be able to bring that in when maybe it wasn't in there before, wasn't dictated to you to be in there? What has been essential pieces to make that happen?
Having the knowledge, I think, having the understanding of the relationship between chronic disease prevention and lifestyle. And I find that as nurse practitioners and providers of care, whether you're in advanced practice of being a physician, or physician's assistant, or a physician, that's really the majority of the cases we see in our practice. Individuals suffering from diabetes, obesity related conditions, heart disease, and so on. And heart disease, having worked in cardiac rehab as a very young nurse and knowing that it was the number one cause of mortality back in my 20s and continues to be the number one cause of mortality in my nth decade. I won't say how old I am, but many years later is so concerning to me and disappointing, right? Because we know that it can be prevented. And we've known this for many years. And for me, I have a passion to teach that to my students, that we can help so many people if they, and I know some providers tend to think that patients won't change and they can't change. And there are definitely some barriers to change, but many people, if they're given the information, will make those incremental small step changes. And if they're empowered and encouraged and they realize it's important to the provider that they make those changes, and they can also see the difference in how they feel, they will make the changes. And I've had many patients over the years that I've said something, and sometimes I don't even know what that something is, but they'll come back and they'll say, something you said, and I'm now doing something different. I've quit smoking, or I'm eating differently.
I love that. What do you think has been the response of the students of this kind of education? Have they liked it, embraced it? Have any of them changed?
Oh, so I teach a class, Advanced Health Promotion, and in that class, I integrate all the lifestyle concepts. And I also have an assignment that I have the students do a reflection journal. But before they start the reflection journal, they need to do an assessment on their health behaviors. I have an acronym that I call ASMART, that stands for Adopt Healthy Eating, Stress Less, Move Often, Rest More, SMART, Avoid Alcohol, Rest More, and tobacco cessation. And I have them assess where they are on those 6 lifestyle behaviors. And then they are to select one of those behaviors that they want to improve on over the course of at least 21 days or more. So I actually prefer that they do it across the semester. But if they want to change, say they start on eating and then they say, okay, I've mastered that. I've gotten to a place where I now want to work on exercise. They could change, but they need to spend at least 21 days, because the literature does support that at least 21 days on a behavior change will make it more sustainable and more likely that they'll maintain that behavior change. So they do that, and they journal every week, just on a journal that only the faculty will read. And they use evidence to support their change and theory to support their change, behavior change theory. And every week they document on their progress. So they do a baseline assessment, and then every week they document on their progress. And so since 2017, I've been teaching that course. I've seen students make tremendous progress in behavior change. Some people have had struggles with alcohol, weight management, just nutrition, sleeping, stress. And so they document their journey, and many of them have had excellent results that they've continued even beyond the class.
Mm-hmm. I love that, because it's experiential.
Exactly. And it's so easy for us as providers to tell patients that they need to change their behavior. But when we recognize that it's not as easy as just saying change, but we look at all the factors around change, and when the student has had to go through that and see how difficult it might be to make those changes, then they also will be able to empathize with the patients as they come in and make it more of a collaborative, patient-centered approach.
Yes, I love that. I wish I would have had something like that was more experiential, and not just experiential, but personal for you would be really nice. So, do you collaborate with other people within the health sciences other than nutrition? Or, and even how have your colleagues responded to some of this?
So my colleagues have been very receptive for the most part. We have a very social community. So I think one of the things that I sometimes, and it could be my personal perception, but alcohol tends to be a very common thing that people socialize around. And particularly, um, alcohol has so many negative effects that we don't always recognize. But ever since we got the Federation report out that said that there's no amount of alcohol that could be considered healthy, it's just hard to justify sometimes why we continue as health professionals to embrace this behavior, although it's a very social thing that we do. So sometimes I think I get shunned. Was my personal thing because I'm not supportive of that type of behavior. But for the most part, my colleagues are very receptive and they are embracing the lifestyle changes. They tend to look to me for guidance in some of those areas. But my colleagues are very welcoming and seems to want to make changes too, personally and sometimes with students.
And we know as nurses, and one of the calls to action in the future of nursing reports has been for nurses to take care of themselves as well.
Definitely, yes. And that's why that assignment for me is important also to build resilience and to help my students to recognize, particularly now more than ever. When I started in 2017, I really didn't think about resilience. I didn't think about the burnout that we're seeing in health professionals right now. But currently, even in the last month or two, we've heard of so many health professionals that have succumbed to the stress of healthcare. And over COVID really has really shone a bright light on how stressful it is to care for others if you're not caring for yourself. And so why that is so important. So that assignment is very important for me. And I highlight that for my students.
Right. And the pandemic has put a whole new lens on all of that, including social inequities and our care for ourselves or lack thereof, and that kind of
Right.
thing.
And also, you bring up a point about the social determinants of health. That is something that I also integrate into the course because we have to look at all of that. We can't just tell patients they need to eat a certain way when we haven't assessed their financial barriers, their living conditions. Do they even have access? Are they in a food desert? And how we can tailor the education around some of those things. So they may not be able to go out and get fresh fruits and vegetables, but we can educate them on how, if they're going to a food pantry, how they can hopefully use some of those foods in a healthier way, rinsing canned foods and really helping our patients to see how they can use what they have in the best way.
Right. Because it doesn't have to be as expensive as people think. Right.
Yes, I actually have done a presentation over the years, some foster children, to let them know that they can eat healthy on a diet. And there's really good, you may not eat as lavishly or the variety, but the beans and rice don't cost that much money. And a frozen bag of vegetables can last you quite a while, and a bag of apples, it will go a long way versus running into a fast food place and buying one meal. You could probably get several meals out of that cost that you spend for that food.
And I do have a question for you. And if you want, we can cut it out. It's a little bit of a personal question, which is when you changed your diet, did your family or community give you the stink eye? Or I'll give you an example. Like my in laws live in rural America, and comfort Southern food is the way of life. So I'm just curious from your background, your racial background, your personal background, was any of that troublesome for you as an individual?
So I grew up in a faith-based organization, like I said, that promotes healthy living.
Mm,
Not that you needed to be plant-based, but in general, there are certain things that we considered not healthy, certain meats that weren't healthy. So although there was meat in my diet as growing up, as I got to an adult age or after college, I decided as personally that it wasn't from the evidence healthy to eat meat. And so I made a decision to eat more plant-based and to become a vegetarian, not always vegan, but vegetarian and plant strong. So my immediate family, my children, and in my home, our meals are typically either vegan or vegetarian, and they've embraced that. My broader family, they still eat healthy, but we still will have, and I still will have family that will have meat around the table if we have a large enough family because that's what they prefer to eat. But they actually embrace the vegetarian eat food, and sometimes we have to tell them you can't double dip because they want to eat the vegetarian and the other types of food. So we have to restrict them at times because oftentimes there'll be many options for the meat eaters and not as many options in terms of the proteins for the vegetarians or plant-based eaters.
right.
Yeah,
Right.
it hasn't been a struggle for my family in general.
Good. I feel like food is so social and familial and cultural. That can apply across the board. But
And I usually tell people who are afraid to feed me, I eat everything except the animal. I can eat just about anything else. As long as you have lots of vegetables and other food, I'll be fine.
how do you stay updated on all of this science around lifestyle behaviors and lifestyle medicine and lifestyle nursing and how powerful these things that seem simple can be?
So for me, attending the conferences is really helpful. So having PPOD or having PCRM or lifestyle medicine, the conferences do help. And being a certified lifestyle medicine health professional, I get to do CEUs and to maintain my credentials. So having to read the journal articles, and so that helps, forces me to stay on top of it. But also being in the academy as a faculty, you're forced to read more and continuously learning. And I have a insatiable appetite for learning. I'm always reading or listening to a podcast or listening to an audiobook. For me, it's not very difficult because I enjoy it.
And I'm the same way. So my husband will say sometimes, stop listening to things all the time. So I have that same insatiable appetite. And I guess the people who are educators are also lifelong learners, right? Which I feel like nurses are anyway, generally speaking. I might turn it over to Deborah to get a little bit into the Future of Nursing report, a little bit about that. Is that okay?
Hi. Thank you,
Hey,
Sue.
Deborah.
Hi, Dr. Downs. Hi. How about if we talk a little bit about the intersection of nursing education and the future of nursing 2020-2030? It is the vision that informs that report is the achievement of health equity in the U.S. built on strengthened nursing capacity and expertise. You are a leader way out in the forefront on nursing education and have integrated this into your DNP program that you are leading. Can you share with us where you think we are in this process and what needs to happen?
Deborah, I think we have come a long ways, but there's so much more to go, right? There's much more work to be done. We know that we have a lot of inequities and food deserts and social determinants of health is impacting so many people. And COVID has not helped in terms of the loss of family members who might have been breadwinners. And just as there's been a lot of loss and change as a result of COVID. And the light that COVID has also shed on chronic disease and the inequities in terms of those who are more likely to succumb to COVID-19 were those who had those chronic conditions who were not managed well and chronic conditions that could be prevented. I think nurses have a definite role to play. And one of the ways that I've tried to work in that arena is I didn't bring it up earlier, but the full plate diet, I've done some research using the full plate diet and that resource that's been provided for us That's a free resource that we can use in the community, in organizations to help people change their eating habits, but it's also a resource that they can always go back to. And I've worked with ACLM to adapt that full plate living curriculum for African Americans and faith-based organizations, and they've used it in Louisville or in one of the other states. I'm not sure, remember which one at this point, and I've also used it in my own organization. And even before that, I had used it with African Americans and older adults and communities to help individuals see that it's feasible. I think a lot of times people see healthy eating and health behaviors as something for the elitists, but it can be brought down to a level where anybody can participate just by changing the order of what they eat and powering up their meals with those high fiber foods. And you don't have to take everything away from people who enjoy certain types of foods. If they like a slice of pizza, they can still have a slice of pizza, but they have it after they've had a large salad with their beans or whatever else they need to do. So there's so many ways that we can educate individuals, and nurses need to be empowered to educate patients at all levels about the importance of the diet and how it can be implemented across areas that are more likely to suffer inequities for individuals.
Thank you for that. So that curriculum, the Full Plate Living by Ardmore Institute, is free. It's accessible to everyone on multiple platforms, either the printed version that can be purchased or online. All of it is free, and the videos, and it makes it it's very amenable to everyone's different, changing it culturally depending on meals, and it's flexible and allows people to be plant forward and then those other foods as you were describing. So it, yeah.
And backing on that in education, I have two students who are using it for their DNP project. One's using it for obesity in the African American population. She's going to do a virtual project with that. And another is going to use it in her Hispanic faith-based organization to help with hypertension. It gives you the versatility of the product. And she's going to tie it in with the DASH diet and using it as a DASH diet adherent protocol.
Wonderful. Thank you. Speaking of that, with the students, and you work with students at all levels in the university and are engaged in the development of curriculum and evaluation of it, leadership at the national level in the various nursing education organizations. Can you share with us a little bit about how you would describe the scope and practice of BSN nurses to speak to their patients about diet, about healthy eating?
Deborah, I primarily work with graduate students, doctoral level students, but our undergraduate students usually have a nutrition education course that they're required to take as part of entering into nursing. So they do have that nutrition background, and they also do a lot of community health work. And in their community health work, they have an opportunity to do some work with individuals in the community to help them across different needs. And our undergraduate students also have a wonderful opportunity to be educators and to be champions of health for the patients who would need it.
Wonderful. It sounds like at your university you're really implementing clinical rotations for students from the bachelor's level on up into the community where more and more healthcare is needed and provided, moving out of that acute setting where many of us did all of our rotations and into community settings.
Right, yes. And the new Essentials definitely also promotes doing clinical work in the community. And we've already been doing that. So we're already ready to take on the new challenges of the Essentials and help to educate our students to be better prepared for population health.
Can we touch briefly, you had mentioned this, on you spoke about nurse burnout and healthcare professional burnout, but particularly to the nurse and how all of this intersects the lifestyle medicine, the education that they're receiving, and nurses when they go out there to take care of themselves as nurses.
There's evidence that talks about role modeling. And if we as nurses and advanced practice nurses are role models, we're more likely to educate our patients. If I am more likely to educate my patient if I like to exercise, if I'm an exerciser, or if I eat healthily, I'm more likely to educate my patient about eating healthy. So it's important to have our nurses and be role models and practice these health behaviors so that they can then translate it into their patient care. In terms of burnout and resiliency, if you're practicing, there's a correlation between diet and mental health. There's a correlation between strong evidence-based correlation between individuals who are 150 minutes practicing physical activity for 150 minutes per week or more of moderate to vigorous activity and their mental health. If you're sleeping the recommended amounts of 7 to 8 hours, if you're an adult, you're going to have improved mental health. Across the board, these lifestyle behaviors are going to improve overall well-being and mental health and decrease burnout, increase resiliency, and just make us a more stronger workforce to help care for those who really need us most.
Thank you for that. That's really important. Might we touch on team? We had spoken before, I believe, the recording about the integrated team and the role of nurses. Might we touch on that also then, and how nurses could be even more fully utilized and also fulfilled as nurses in various settings, and take us through maybe some of those settings that you see nurses in?
Oh, definitely. I think healthcare definitely is a team sport, right? We are all working on the team of helping patients live longer, healthier, more fulfilling lives. And I don't think anyone goes to medical school or nursing school expecting to see patients get sicker and sicker. We want to help them feel better. So I think we're all on the same side in terms of our getting into healthcare. And so I think we need to use each other for the strengths that we bring to healthcare. And nursing education has always been very strong on patient-centered care, health promotion, and disease prevention. That's part of the foundation of nursing education. And so we are well suited to educate patients about health behaviors, dietary habits, physical activity, non-pharmacological therapy, as well as adding the pharmacological therapy when needed. But if we can address these primary prevention needs and get patients to early on, before disease, prevent disease by talking out to our patients early from childhood, having more community-based programs, parent-child programs, where we can start instituting health behaviors through faith-based organizations, through community organizations, senior centers where the seniors are. Now we have an aging population. People are living longer, but they're also, some of them are sicker, and most of the healthcare dollars are spent at the end of life. Why not spend dollars early in prevention? We spend more dollars on the end of life when someone's really not going to recover than we do on prevention. So if we can flip the switch and flip the script so that we can do health prevention very early when that child is born, start talking to mom about what are the foods that mom should be feeding the child, what foods to avoid, particularly if a mom has a 9-pound baby, she's already set up for high risk of diabetes. So why not start the education early to say, if you can breastfeed, when the child starts to eat, and when you're handing him those foods and testing his taste buds, hand him a piece of broccoli while you're in the kitchen. Start getting the child to help you in the kitchen to cook healthy meals that will set that child up for success for the rest of his life in terms of his health and overall well-being.
Thank you. That's a beautiful picture. How do you think we're doing about getting nurses to where they need to be and giving them the tools that they need to address social determinants of health and disease prevention and health promotion?
We are making strides. We are definitely making strides. Social determinants of health has come to the forefront. I know the National Organization of Nurse Practitioner Faculties has a toolkit. They have a special interest group that's working on that, but there's a toolkit available for nurse practitioner faculty to use in the programs. And so there's a lot being done. We know that our physician colleagues are also working on social determinants of health and are actually as mandates to assess for social determinants of health, particularly in certain organizations where they're caring for those individuals. And so it's built into EMRs where they are assessing more for those determinants of health and building in the healthcare team where you have a social worker or a case manager who can help to address those needs. Because assessing it's one thing, but if you're assessed, you need to have somebody available to do something about it. It's important to have that team approach because we need to everyone on the team. And that's why I think we need the nurses, social workers, we need everyone, the physicians, and everyone working on the same team to help the patients.
Thank you. So it sounds like if we're in an environment where that's not really present, we can be the ones to start the conversation.
Definitely. Nurses can start the conversation. We're well equipped to do that. And to our Doctor of Nursing Practice students, they're educated around systems theory and systems approach and change theory on being change agents for healthcare. So we have many nurses capable of starting that conversation and beginning to be change agents for better health outcomes.
Wonderful. Thank you. As a researcher, also, in addition to a university leader and faculty and practitioner still of healthcare, are there any studies that you would like to see or that you feel that we need to do around any of this, and including studies around the nature of teams or the structure of all of this, possibly different types of research?
And that's a really good question. I think indeed we need more literature, more research on best practices that we can utilize across different healthcare sectors that would serve us well. So I think there definitely could be more research as to the ideal team makeup and who should be on those teams. I think we need our physical therapists, we need our occupational therapists. The team is really we should be able to tap into all these individuals. If they're not immediately available, then we should have them as a resource for us.
Thank you so much. I'm going to ask Susie, would you like to jump back in here? Thank you so much, Dr. Dan.
And Deborah, as I said, like the physical therapist is so important. We have pain as such a big issue with the opioid epidemic. And I think if we utilize these team members, the occupational therapists, and in particular physical therapy as it relates to pain, and they can really do a lot. I had one of the staff popped into my office the other day and she said she was having severe foot pain, just came out of nowhere. And she has some autoimmune problems. And one of the physical therapy faculty came up and saw her limping along and she described the pain. He did some manipulation. Pain went away. I really think we need that team approach.
That's so important. And coming from the VA, we had acupuncture available to veterans. We had massage therapy available for our veterans, and then the whole behavioral health field. That's in another area that we won't have time to explore today. But equine therapy, dive therapy, so many modalities. That team can be really beautiful and very diverse, and even grounded into community health workers, which are many countries without the resources that our country has, is people in the community, faith-based nurses.
Yeah, that was great. I always want to go back to school after I talk to nurse educators. I'm like, I want to go back to school. So just to wrap up our conversation here towards the end, I would like to know a couple things. What advice you have for other nurse educators who want to incorporate these lifestyle pillars a little bit more, put them in the forefront a little bit more, what advice you would have for them? And if there's anything that we didn't touch on that you think is important that we should discuss.
So this might sound a little self-promoting, and I'm not a self-promoter, but as you said that in advanced practice, you mentioned that I have co-edited a text on health promotion, disease prevention using lifestyle medicine concepts. And the way the book is put together to be a very practical resource. So we have these lifestyle prescriptions embedded into the chapters. And so it can go right alongside the evidence that says that those lifestyle behaviors should be primary treatment, and help give the language to providers and to educators who would be looking for that. We're so familiar with giving the medication prescription, right? And we teach that a lot, but teaching students how to integrate lifestyle prescription into practice and making it real practical, giving those patients those practical lifestyle prescriptions written in measurable ways, and not just you need to walk more or you need to exercise, but being specific and giving and meeting the patients where they are. So that's one way that they could integrate it.
So the second part, was there anything that we didn't talk about that you think would be important? But before we do that, I want to say the whole name of the book again, which is Advanced Health Promotion and Disease Prevention for Advanced Practice, Integrating Evidence-Based Lifestyle Concepts.
And it will be ready in October, by the end of October this year.
Oh, good.
Yes.
That's awesome.
It's interesting. It's already being promoted on Amazon.
Oh, good. And which also coincides with the ACLM conference, right?
Correct. Yes.
But the last question was, anything we didn't talk about that we should talk about?
I have enjoyed this present interview. I enjoyed speaking to you and Deborah, Susie, and thank you for the opportunity. I just really want to say congratulations to you for doing the work you're doing, and to just continue to spread the word about how beneficial and lifestyle is, and to help other nurses be empowered, to let them know that they can do it. They just need to start personally, I think, doing what it is that they would want to do, and then being a role model for that activity or that behavior change, and then it will just spread. It's like you need a spark, and then it will spread. And we don't want to talk about fires right now because we know how terrible that is, but they just need to start.
I agree. And the other last thing that I was thinking about, I so appreciate you being with us, because this will shine a light on the people in nursing education, where as nurses are looking to further their degree or their life in nursing, that they will know the places to go to find this information and engage in this kind of education. Yeah, you're welcome. Deborah, anything else?
I think one last thing might you share an example of what with your school of where nurses, just first or second year nurses or newly graduated nurses, are having the opportunity to actually stand this up and do this. It's like a success stories for nurses when we talk about for our patients.
So I know of students who are practicing these behaviors personally. And I am, like I said, once a person is doing this personally, it will just spill over into their practice, because you just can't help but share. I don't have a specific story about a student that's gone on to work that I can recall off the top of, but I do have students who are working in employee health, and trying to think of anywhere else at this point that would be directly related. I have a student who's doing wound care, I know, who's applying some of those principles, because wounds don't heal if you're not eating bad and improving your diet and things like that. There's lots of opportunity to put this into practice in every aspect, particularly primary care, where you're trying to improve diabetes and high blood pressure. And I know those students are currently working on their DNP projects related to the full plate living. We'll definitely take that with them when they're finished.
Thank you. And I think to circle back to that, we practice and then we teach. And as you said, a student can't help, a nurse can't help but educate their patients. If they're taking care of themselves, exercise, physical activity, eating healthier, that will naturally just come through in their patient education, their patient communications. It will be infused in it. That's really important. We have to get this to our students is the bottom line, the most important thing. Yeah.
Thank you, Dr. Downs. Again, I really appreciate you. I know Deborah does too.